everyone. Please, if I could have your attention. My name is Sydney Stern, and I am with TGCT Support, and I want to walk you through some of our resources if you aren't accustomed to them, and then I will pass it over to the prolific Dr. Randall, Dr. Tapp, and Dr. Stacciati. So a little bit about us. My name is Sydney Stern, and you'll see where I fall into this dynamic, but the Life Raft Group, which many of you have heard of because of GIST, is a nonprofit patient advocacy with a long history of supporting patients. And they went into a TGCT Facebook group, my group, and said, would you change your diet essentially for a drug to work better? And they got this huge pharmacokinetic style answer, and they said, who is this person? And it was kind of love at first sight. And so me, LRG, and the TGCT community started TGCT Support in 2019, and if you're in the TGCT world, you have probably heard my name or TGCT Support far more than you'd like to. Why? Because we have so many important resources. We have virtual TGCT support groups that many patients attend. We have mentor programs where we pair patients with local patients that have similar disease characteristics or demographic characteristics. We have TGCT Days of Learning, and those are very special one-day events where patients get to meet experts as well as meet each other, often for the first time. We have virtual tumor boards, we have educational programs, and we have a specialist list, which is known as the Bible, or the Holy Grail of who are you gonna see for TGCT. We also have research, which tomorrow we have a talk and you'll hear more about, as well as a registry, which is pumping out data faster than probably you guys see patients. And then we have a lot of advocacy efforts, not only to change how patients are seen, when they're seen, and who sees them. This has resulted in a collaboration for a publication with SPAN, as well as all of the doctors that you'll hear from later today, as well as patient versions of that same consensus paper, which really talks about the management of TGCT from a multidisciplinary approach, and what you'll learn is that's the gold standard. We don't just speak English, we are a global organization and we want to make sure that's represented. So we have French versions, German versions, and Spanish versions as well of the same document. We don't stop there. Our registry is the largest and only global registry for TGCT. We have 1,500 patients in that registry in 2 years. And it's a little recent, but recently within this year, we published localized and diffuse patient, a real-world observational registry data with 500 patients. I'm happy to say we are 3 times larger than that now, and you can read that with the QR code. We also have multiple papers currently in revision, one on pediatric patients, which is a desperate unmet need group that resembles adult patients, as well as how socioeconomic factors influence both the diagnostic journey as well as management of disease and after, and you'll hear more about that. We also have a current in-submission consensus paper, which is based off of the UK perspective. And it's really important that we have regional resources that are allotted based to TGCT. And so this introduces those specific regional challenges. We also present at conferences. That's why I'm here, right? So we presented at CTOS in 2024, as well as ASCO, you'll see below. And so we participate in every aspect of TGCT we can. And what you'll see is tomorrow at 2:30, I gotta plug it, on Friday, you'll see us also give a talk about the impact of adverse social exposomes on treatment of TGCT. So we have a large breadth of patients in our group. We have these conferences, which I've seen, which are well attended. Between 60 and 80 patients attend from all over the world. And you'll see that our community represents 53 countries. So I saw CTOS has 55 countries represented. We are not that far behind. And where do patients find information? I get to ask that all the time. And what we've learned is they find most information from us or their provider. And what you'll see is information related to clinical trials is almost 61% found by us. And so we deliver cutting edge information often for the first time to patients. So I mentioned our registry. We have 1,577 members currently, as well as a giant cell tumor of the bone, because those are often confused for each other. We have current projects like to understand the treatment needs of patients based off of their symptom status, which we just presented a poster on. We also have modifiable risk factors, which you'll hear more about tomorrow. And then how we compare patients' journeys, whether pediatric patients or adult patients are similar, and how can we address the fact that indications are only for adult patients. We thrive with this collaboration. These amazing doctors, I've probably emailed all of them personally to try and help patients. There's a great collaborative effort, and we need you. So that's a big part of why I'm part of all of this, is to facilitate both tumor boards, registry data to help you find answers about what's the best way to treat patients in a real-world setting, and then how we support these patients through their journey so they're the most educated they could possibly be when they get to you. Thank you all very much. The QR code to the website is there. Please feel free to reach out at any time for any questions.
So thank you, everyone. It's truly an honor to be here with you tonight, and I appreciate that you're sharing some time at CTOS and your dinner with us. And we're very excited to talk a little bit about tenosynovial giant cell tumor. First of all, I want to thank Sydney Stern. Sydney is amazing. If you didn't notice, in just the 6 minutes of what she's been able to do for patients with tenosynovial giant cell tumor, and inclusive of that is TGC Support and LifeRaft Group. But one of the things that's amazing about CTOS is the partnership between a lot of the physicians here and the patient support group. So that's instrumental. So thank you, Sydney. Thank you, LifeRaft Group. I am honored to have the president of CTOS, Dr. Silvia Stacchiari, as they were saying at the meeting today, and of course, Laura Randall here and to share the evening with you. And today we're going to be talking about achieving disease control in tenosynovial giant cell tumor, critical steps for integrating evidence-based care with CSF1R inhibitors. And we are going to get started. I can tell you the lights are bright. We cannot see you. We can hear you. But feel free, throughout this to be interactive, and there'll be some QR codes and other things. I introduced our esteemed panelists today, and we want to thank you and peer review and TGCT support, as I said, for providing this session. This includes Daiichi Sankyo, Decipher Pharmaceuticals, and Merck KGaA, so Darmstadt, for providing the educational grants for this symposium. Look out for additional polling during the presentation, as I mentioned, and submit your questions. And here's just some information where this can be viewed. You can, again, scan the QR code to see the slides. There are ways to join the conversation on social media as well. So what are the goals for today? Well, during this presentation, we are going to learn, while surgery remains the mainstay of treatment, and we put that in there for Laura, post-operative recurrence in diffuse TGCT is widespread, and we'll talk about diffuse TGCT. Systemic treatment options, such as CSF1R inhibitors, are available for patients with TGCT who are not amenable to surgery or have recurrent or progressive disease, and discussing a little bit about the nuances of what these means is important. And then cancer care teams should be prepared to work cohesively across disciplines to identify patients who might benefit from CSF1R inhibitors and manage practical aspects of care and delivery. Basically, what that's saying is we believe all TGCT patients should be seen in centers that are familiar with the disease, that have a multidisciplinary approach, and we always include the patient in that, right? Because ultimately, the patient's needs are paramount in how we decide treatment with them, right? So that's a critical thing that we'll talk about. So I'll start. This is titled A New Puzzle. We have many puzzles in sarcoma. This is a new one, and it's addressing challenges and unmet needs in tenosynovial giant cell tumor. So most people in the audience know this, but tenosynovial giant cell tumor is a really locally aggressive inflammatory neoplasm that occurs mainly in the synovium of joints, bursa, and tendon sheaths. And we're very careful with our language here in which we call it inflammatory neoplasm. And you can just see some pictures here of tenosynovial giant cell tumor in the knee. And we'll discuss this a little bit more, but you can imagine the symptoms that can cause an individual. So it can cause a lot of morbidity. The WHO classification has different histological cellular subtypes, but what's important to realize is that this is really an attraction of different inflammatory cells to the joint because there is a neoplastic clone that secretes CSF1, right? So they will attract CSF1 receptor-bearing inflammatory cells to the joint, and that's what causes these tumors and tumor formations. The disease was originally called pigmented villonodular synovitis and tenosynovial giant cell tumor of tendon sheaths. Now it's all under the name of tenosynovial giant cell tumor. And those are just some histological representations of it. These are rare, and we talk about two different types, and this is really important. There's one that is called localized. I don't think that's the greatest term. We often use nodular, and these tend to be very small and well circumscribed lesions. They're often encapsulated. We often see them in the extremities. And the reason we like to distinguish these tumors from more of the diffuse type, which we'll talk about, is because these are often curable with surgery alone. Then there is more of the diffuse type, which are large, often multiple masses. These are infiltrative processes within the synovium. They can be very destructive and locally aggressive. And this is just some examples. So you can see on the left side of the screen in the localized type, you see more of this nodular form. So you can imagine surgically that could be very easy to encompass and take out. Whereas if you look at the diffuse type, it's very frond-like. And I don't, Dr. Randall can talk about this later, but surgeons would always tell me it was like operating in mud. We just couldn't get around the tumor, and it's really infiltrated within the joint. And because of that, I think it's not a very rewarding procedure sometimes for surgeons and patients alike. But understanding the differences are important for this conversation because we'll talk mostly about the diffuse type, which is less prevalent. So it only represents about 10% of all cases of tenosynovial giant cell tumor, and the incidence is estimated to be about 4 cases per million in the United States. So not an ultra-rare disease, but a rare disease. Now, it's also important to realize that tenosynovial giant cell tumor can affect any joint in the body. There's a preponderance for the larger joints, the knee, the hip, but it can affect any joint, and it's not something that we see multifocal. So if a patient presents and they have a multifocal diagnosis of tenosynovial giant cell tumor, something is off. I think I've only seen one case. I think, Sylvia, you said you had 2 cases or so. So locally aggressive, but it's considered a benign tumor. Benign meaning that it will not metastasize and kill a person, but it can definitely be something that causes significant amount of morbidity, can be swelling, decreased range of motion, cause a lot of pain. So although not threatening a patient's life, it can change the trajectory of their life. And this is something that often affects younger patients, median age of about 40. There's a slight female to male predominance. So again, here are some additional characteristics of the large type. I think if you just look at how this tumor was outlined, you can see how extensive it is, and the extent of surgery to cure this is limited, and we estimate anywhere in tumors like this to have a recurrence rate of about 50 to 70%. So that means that surgery is often not curative, but surgery can be very palliative, and patients can undergo surgery, recover from their surgery, and actually have really long periods before the disease affects them. We spoke a little bit about the symptoms, but one of the things that we need to talk about is that this is often misdiagnosed in patients. Younger patients, they present with pain. You can imagine the hundreds of things that this could be. They end up in primary care physicians, endocrinologists, sports medicines, and they don't have a diagnosis, but rather are treated symptomatically. So we have stories of many patients who have dealt with this for years before they actually get a diagnosis. And then when they finally get a diagnosis, they're often treated by sports medicine physicians, local orthopedics who don't necessarily understand the disease. So it can be some time before they make it into the hands of an expert, generally an orthopedic oncologist, who can really think about what's the right approach to patients. And this is just an example of, the 7 or 10 years that a patient can go through. And so patients often report that they spend a lot of time in this circular, complaint and seeing physicians, but not a lot of direct diagnosis or then appropriate treatment plans until they meet the orthopedic oncologist. And more recently, because of drugs, the sarcoma medical oncologist is also involved, but it is that team that really helps take care of the patient. So with this, I'm going to pass on to Dr. Randall. It's really important as a medical oncologist, we had to learn this disease from our orthopedic oncology colleagues, right? So they really had to teach us that, and then spending time with patients, again, to understand how the disease affects them. So the true expert in the room is Dr. Randall, and here we go.
Thank you, Dr. Tapp. It's a pleasure to be with both of you, and all of you, thank you for taking the time. Some of this will be redundant. I'll move through some of this a little bit quickly because I think some people either are experts in it already or have heard this already through the erudition of Dr. Tapp. But we talk about giant cell tumor of, TGCT being highly morbid and aggressive, but let's temper that a little bit. There are plenty of patients with TGCT that are doing just fine. There are some that are not, and that's what we're talking about. But listening to our patients is really first and foremost because this is a quality of life. We're oncologists. We think about survival curves. Well, this is quality of life curves, not survival curves. People are not dying from this disease. They're living with it. It's like diabetes. You don't want to make the treatment worse than the problem. You want them to go hypoglycemic or hyperglycemic. You want to keep them in the sweet spot, and that's what we're trying to do with multimodality therapy in the current era of TGCT. You've sort of seen the demographics and the gross features. You can get some collagen deposition from scarring and some subchondral erosions I'll talk about, and hemarthrosis. And we can read the clinical features there. That'll be recurrent throughout the whole talk. So MRI is the diagnostic procedure of choice, okay? As orthopedic oncologists, we like to get radiographs, and we will follow in partnership with our medical oncologist anyone who is undergoing either active surveillance or treatment. We, as the orthopedic oncologist, do want to follow with periodic radiographs to look for those secondary changes. It can happen, as we've published in others, in about 20% of patients from secondary erosions. CT scan can be used in some patients who have contraindications for MRI. And historically, surgery has been sort of the backbone standard of care. But as we've already heard, it isn't always doing what we want it to do. So as relates to an MRI, there's a lot of features and there's a lot of different ways that I'm certainly no radiologist, and there's a lot of different spins that they do on the protons to get them to do all kinds of fancy things. But what you really see on the MRI to the untrained eye is you see the hemosiderin deposits, which are the darker spots here, where you have the signal void. You can have this gradient echo where the spin is in a full 90 or 180 degrees. It allows the proton to resonate in a different way, and you can get some more specificity with that. This blooming artifact arises from the hemosiderin, so the tumor can actually look a little bit bigger on MRI. So you want to control for that over time. And then again, you want to carefully assess for secondary osteoarthritic changes. So this is a nice example of separating out the different types of series of MRIs. This is proton density weighted MRI on the left with fat suppression, and then a T1 of the same lesion on the right. And what this is telling us is the extent of the disease. This is all disease, but this is a synovial outpouching in the back of the joint that here you might say, is this all tumor? Well, this has got tumor in it, but it is really just synovial fluid that is ruptured through the back of the capsule or extended the capsule out into the back. So you can get a lot of information from the MRI, and working with our MSK radiologists, we can really get an assessment of the extent of the disease. So before we move on, do take a moment to answer this. Give you a second, but then I'm going to keep moving forward. We have a bunch to get through. This is a very nice paper by Masloom et al. Looking at this severity classification using MRI. They had 283 patients. Some were excluded for a variety of reasons. 60 were not therapy naive. They probably had had some PEXI. Some were not primarily treated with a synovectomy, and 10 had no pretreatment MRI, so that gave them an N of 174. You can see the types, localized versus diffuse, articular involvement. Obviously, with the nodular, it's almost always in the joint, and so it's not included there. But with the diffuse type, it can be intra or extra, or intra and extra. And then the involvement of critical structural aspects to the joint gives us some predictive value. So if you've got localized disease that's pretty mild, small, for example, your relapse-free survival with the surgical excision approaches 100%, 95%, 94%. We really don't have many local recurrences. Severe localized just basically means a larger nodular variant, so you would expect some of those might get an incomplete excision. And then when you get into the diffuse, obviously, the more extensively involved, the higher the recurrence rate. So the relapse-free survival at 4 years for the severe is approaching 40%. So here's a typical case. Tamara is a 40-year-old female patient with an effusion. You can see the MRI, that the arrows, excuse me, highlight the disease. As many of these patients experience, they were seen by a sports medicine physician who feels they're doing the right thing, as they should, but they're also incentivized to do these sorts of procedures. They go in and scope it out and clean it out. And this particular case, with it being an epiphtheal fossa, even with a master sports technologist, they're going to have a trouble getting all of that out. And no surprise, 6 months after the arthroscopic excision, she's got local recurrence and is having symptoms as if she'd never had the procedure before. So this is a good moment to emphasize that in retrospect, this patient should have been counseled on all the multiple modalities of treatment. Did they need intervention with surgery? Could they have gone on a CSF1 inhibitor? Those are debatable, but we bring them to our multidisciplinary tumor boards. But there's definitely room for improvement for the average patient to make sure, this is a take-home message, that these patients are being counseled by a group of providers. This is another patient of mine, 41-year-old male who presents with this disease. It's extensive. It's not so extensive, but it's pretty extensive. And so for this patient, I actually counsel them to go on CSF1R inhibition. There's lots of questions like how long, all those sorts of things. But what's really important, again, is the multidisciplinary team approach. Localized disease, even for our local cases, for quality assurance, we put them through our tumor board, and we don't spend a lot of time on it, but I say, this is a nodular variant, I'm taking it out. Probably high probability of being cured by surgery. For other patients who maybe even have extensive disease, maybe they're not bothered by it. If their pain interference and their physical function is not that bad, you can observe some of these patients, and I'll touch base on that one more time before I wrap up. Asymptomatic disease can be watched. So this is from Emanuela's paper. It's a very nice, and you're the senior author on this, very nice cohort of 294 patients. Not surprisingly, as we heard from Bill, 171 women more than men. Median age, right where we would expect it. Size, a little bit on the small side, but you can see the range there, 1 to 25 centimeters. No surprise, most common about the knee, the hip, and the ankle. We do see in the upper extremity, I have a bunch of shoulder cases. Bone involvement in this cohort is about 18%. That 18% is a nice number to hang on to, because 18% is about what we tell patients the incidence of secondary osteoarthritis is with TGCT. Oh, sorry. So in their paper, the new diagnoses made up the majority of cases, and they only had first relapse patients in their cohort. People with multiple relapses were not included in the study, I believe. Smaller percentage. The most that are coming into these big centers are diffuse type, because the nodular are doing well and being treated in the community. As we would expect, it's not a metastatic, there's really no metastatic potential. There can be multifocal disease, but that's very, very uncommon. Local recurrence, they found 28%, with the diffuse 14%, with the localized 14%, with diffuse 36%, and the time to relapse was just over a year, with the 5-year local failure-free survival at 2/3 or 66%. This is a helpful chart. Age really doesn't matter too much. There is a high risk for progression with women, probably just because they see it more, they experience it more often. Size does matter here. The smaller lesions did well compared to those that were larger, and that corroborates the fact that diffuse does worse than localized. What's really important here to show is that the new patients that are coming into these centers, this was 3 centers, I believe, that are experiencing this, and their local control rate, if you will, their local failure-free survival for new patients was 77% compared to relapse. So if the experienced team is seeing these patients up front, the probability of them doing better is there. Obviously, a complete excision is better. This is debatable about open versus arthroscopic, and maybe in the Q&A we can drill down on that a little bit more. But this Kaplan-Meier really does drive home that point I made a moment ago about patients that are coming into centers with experience where they potentially have multimodality therapy, and surgeons that are experienced really can affect better local control than those who are very well entrenched in the community. They just don't have the experience and the wherewithal to manage these very complicated situations. This is another paper by Masblum. This is how all of these cases were broken down in their large series of 966 patients. You can see most of them were treated with one stage, some with two stage. There was potentially one amputation. I have done some amputations for really sort of locally malignant, not oncologically malignant, but really maligning the limb. I've had to take off a couple of limbs because of horrible disease. It's pretty uncommon. But all comers, their recurrence rate was 44%, and the recurrence-free survival was at 5 years was 55%. So this is certainly a problem, certainly a challenge. Here's some more data from their Kaplan-Meier curves, again showing that the new diagnoses tend to do better than those have recurrence. The biggest risk of a recurrence is having had a recurrence before, and if these new diagnoses are treated by people up front with experience, they can do better. The Kaplan-Meier on the right talks about open versus arthroscopic, and I want to be very careful here. Arthroscopy really does have a role in the front of the knee and in certain joints when someone is really experienced. I will do some of my arthroscopies, but if there's a really challenging case, I will get my sports colleagues to come in. I will manage the patient, but there is a role for arthroscopy here in some of these cases, even though as orthopedic oncologists, most of us are more comfortable with the open, more aggressive approach. So as I wind down here, if you've got a new diagnosis, is it symptomatic? Just because you have TGCT doesn't necessarily mean you have a problem. We need to listen to our patients and know that it's bothering them before we embark on any treatment. If they're not symptomatic, active surveillance is appropriate. Orthopedic oncologists need to be involved with that, and they probably are the primary stewards for that patient, looking at the secondary change risk and all that sort of stuff. If they are symptomatic and surgery is highly morbid, then we might actually come out. If it's not highly morbid, the surgery, we will do surgery. It is the backbone of treatment, and it says open surgery here, but I do arthroscopic surgery, and a lot of the front of the knee cases and the back of the knee will do open approaches. If the surgery is we put the yellow in for you, is very morbid, in the United States, there may be a role for some sort of upfront pre-op, I hesitate to use neoadjuvant amongst guys and gals like you, pre-op denosumab, I deal with a lot of giant cell tumor bone as well. Pre-op CSF1R inhibition in select settings. But it's controversial, it's not done in other parts of the world, but it is something to debate and discuss. If you get a partial response, then you can potentially go to open surgery or a drug holiday. If they get a complete response, maybe a drug holiday. But that's a debatable point. We don't know how long to treat these patients. So this is my last slide before I bring on the erudition of my colleague here. Multimodality management is key. Surgical resection is a backbone of treatment in select cases. But I submit to all of our surgical colleagues that we need to be presenting all of these cases, maybe not the nodulars if they have a lot of experience, but all of the diffuse, add a multidisciplinary tumor board, because surgery, like desmoids, is sort of becoming second line in certain select cases. So with that, let's hear the real data. We've got one more question.
So we're going to come to the second part before we start to do some of the discussions about patients and the question and answer. And this is going to be current and future directions of tenosynovial giant cell care with CSF1R inhibitors. And I want to talk a little bit about the history of CSF1R inhibitors in tenosynovial giant cell tumor, because I think in the sarcoma community, it really was a proof of principle, of what can be done in large collaborative processes. So this is going to be a patient that we talk about later, so I'll introduce him now. This is Christopher, 32-year-old with limited range of motion. He works in a restaurant, so he's on his feet a lot. He's referred to clinic. He has an arthroscopic diagnosis of tenosynovial giant cell tumor. seems to be progressing over a 3-year period. Because of this, he's unable to work because of limited range of motion. Think about this before we get to the patient section. What would be the next steps would you consider for Christopher seeing a joint that we depicted earlier in some of the radiographs? But let's think of some of the options. So CSF1 is a driver of this disease, but it was interesting. It was really discovered by Matt Vanderen's lab from Stanford many years ago when he was looking at CSF1R and CSF1 expression across a large range of sarcomas and malignancies. And tenosynovial giant cell tumor was, one of the outliers in expression. And at the time, what he found was a novel rearrangement between CSF1 and a ubiquitous collagen promoter of Col6A3, and this was a 1-to-2 translocation. And what we now know is that the neoplastic clone has some general form of rearrangement. It's not always with this partner, but often in the untranslated region of the CSF1 gene that allows for overexpression. And what that CSF1 overexpression does is it actually recruits CSF1 receptor-bearing inflammatory cells to the joint. And when Matt was studying this disease, it was very difficult because the majority of the tumor is not the neoplastic clone, it's actually the inflammatory cells. So really a lot of the discoveries in this disease have been coming in the last few years as our ability to actually isolate the cells with the rearrangement and study them has improved. It was originally thought that potentially CSF1 signaling was important for the neoplastic clone in an autocrine fashion, but as we are not curing patients with this disease with CSF1R inhibitors, that has kind of disappeared, but we again spoke about the paracrine component of this and the attraction of these inflammatory cells to the joint. This is just the NCCN guidelines in the United States. Pexidartinib is a category 1. We just had vimseltinib approved. But I wanted to put this up here because prior to this, there was a case series from our colleagues in France that showed a complete response to a patient that was sustained with imatinib. So imatinib and nilotinib are weaker CSF1R inhibitors, but they can have tremendous activity. Our European colleagues also ran a phase 2 discontinuation study with nilotinib and showed activity. And importantly, and we'll talk about, patients with imatinib and nilotinib can have really dramatic improvement in symptoms, even if we don't see tremendous shrinkage of the disease. But I just wanted to highlight this. Some of the early drugs that were being developed were in cancer to target CSF1R, and there were antibodies like emactuzumab, which again was really developed in the TGCT space by our French colleagues, and that's off to the left, and then some of the small molecule inhibitors that were stronger CSF1R inhibitors than imatinib, and there is PLX3397, which we now know as pexidartinib. And I just want to give a shout out to some of our original Plexicon colleagues who are here today who really helped champion the development of pexidartinib and TGCT. When pexidartinib PLX3397 was being developed, it was probably early 2000s, and there was some really innovative thoughts to run one of the first basket studies where we were trying to line up diseases whose biology made sense based on the mechanism of action of pexidartinib or PLX3397, which was a multi-targeted tyrosine kinase inhibitor. One of those diseases was TGCT, and we saw swim plots like this where patients were remaining on drug with dramatic improvement in symptoms 4 months, right? Something that we didn't often see in sarcoma, especially at the time. There were some correlated studies, and you can actually see increased expression of CSF1 when you actually use the CSF1R inhibitor, and that was an upregulation on some of the cells. So it was really exciting data. From this, Plexicon helped broker relationships with Daiichi Sankyo, who helped design a randomized phase 3 study. And this was the randomized design that was mimicked in later efforts. And I don't want to go into this, but there are a lot of reasons why this study was designed like this. First of all, higher doses because we just came off of an oncological phase 1 study. We did not know a lot about the natural history of the disease, so a placebo was added because we didn't know if we would see spontaneous regressions like we see in desmoids, and we also had to qualify the natural history. But because it was a placebo-controlled, we wanted a finite endpoint in which we could treat patients, and then everybody could get drug. And so it was very difficult because we had a 25-week primary endpoint where we needed to use response rate by RECIST, which is not a good measurement in this disease, and we were guessing in a way at our alpha and beta because we only had 20-something patients on a phase 1 clinical trial to do this. Because of this, we started with higher doses and then very rapidly after 2 weeks could lower the dose to 800 milligrams. And then what happened is after 25 weeks, everyone could go on to pexidartinib, so patients were unblinded and people on the placebo could get drug. Also, because we were uncertain of the primary endpoint, we needed a lot of secondary endpoints. So this included patient-reported outcomes, so TGCT specific, PROs were developed, novel MRI imagings with tumor volume score were made, and then bringing in goniometry and range of motion, really try to capture the disease. And this was a large effort internationally at the time. Fortunately, this is a disease that really depends on CSF1, and we saw really nice waterfall plots, ones that we're really excited about. The one on top is RECIST at 25 weeks. The one at the bottom is the tumor volume score. So you could see the overall response rate by RECIST was about 39%, so the study met its primary endpoint. And based on these, the FDA approved pexidartinib for the treatment of tenosynovial giant cell tumor in the United States, but not in Europe, which is important. This is actually Sylvia's patient, a patient who had a dramatic response, but had extensive TGCT in the hand, and if I recall, because of the inflammatory nature, had significant anemia and was requiring transfusions, and then had this dramatic response on therapy, right? So it was incredible to see these types of responses in clinic. Overall, though, the drug was well tolerated. It did turn you white, hair and skin because of targeting KIT, wild-type KIT, and you could see increases in transaminases. This is because of activity of CSF1 in the Kupffer cells, so these were predictable, but there was a very rare cholestatic hepatotoxicity, a vanishing bile duct syndrome, which was idiopathic, and because of this, the drug was approved with a REMS, a risk evaluation mitigation strategy, an extensive lab taking, which really, if you follow those parameters and you identify patients who are at risk with seeing mostly elevations in ALK-Phos or some of bilirubin, you could really prevent this from happening. But this was something that we were now using in young people, predominantly women, childbearing age, with a non-malignant condition. So it put a lot of conditions on when we would actually use the drug. And to what Dr. Randall was saying, this is a disease that oftentimes we don't have to use treatment. So we didn't necessarily want to put people in harm's way. But from a proof of principle and for patients who needed it, it was wonderful to have a first in class. This is just some of the ways on the REMS that you have to monitor hepatotoxicity. So you basically do weekly labs for the first 8 weeks of treatment and every 2 months for the next week, and then every 3 months thereafter. The cholestatic hepatotoxicity is exceedingly rare, and when it happens, it usually happens within the first month. And we suspect it was due to the higher dose. We saw very little events of it on the lower dose. There is also a registry with this, and that was very important because we've learned a lot about usage patterns. The pexidartinib capsules now come in a new formulation. There's a food effect, so it has to be taken twice a day with a certain number of protein for patients. Importantly, which we didn't mention before, is that we saw very nice responses, but response by a scan is what's not important in studying these diseases and treating a patient. It's improving their symptoms. And we saw tremendous symptoms in range of motion, patient-reported outcomes, pain, all of the things that are important for patients. But I say that because when I start any drug in tenosynovial giant cell tumor, I need to understand the symptoms that a patient has and what we hope to achieve with the drug. And that's much more important than achieving that than actually seeing a radiographic response. There has been an update in the long-term safety and efficacy of this, and what we see is over time, RECIST really catches up with that tumor volume scale. This is, as you saw, these anterior, posterior presentations are just not captured with a unidimensional measurement like RECIST. But you do see response rates increase into the 60 and 70% range, right? No new safety signals, but again, it's more about how you're controlling pain. And I can tell you is that a lot of patients start these drugs in extremis, but after a few months when their symptoms go away, it's often the side effects of the drug which become more of a burden to them. So really working with them to understand how long to use the drug is important. And this is just to show that as long as patients stay on drug, we often don't see progression, but we don't advocate that patients stay on drug for long, long periods of time. And now finally, after standing here for an hour and on our feet all day, we'll let Silvia, Dr. Stacchiati, have a few words.
Thank you, Bill. Now we move to a different class of drugs called switch-control CSF1R inhibitors. This class of compound enter our story of sarcomologists with GIST, with a drug that you all know, which is ripretinib, and was created to overcome the resistance to drugs like imatinib that can block the protein by entering the ATP pocket. So switch control inhibitors are drugs that lock the protein in the inactive conformation, and in such a way they prevent the function of the pathway. Here today we are talking of two different drugs. One is vinceltinib and the other one is pimicotinib. They both belong to this class of agent. And so let's start with vinceltinib. Vinceltinib is an oral switch-control tyrosine kinase inhibitor that inhibits in a selective way CSF1R and has been investigated in TGCT within a study that is called MOTION. This was a phase 3 global study, randomized, where vinceltinib was administered to patients at the dose of 30 milligrams twice per week, and was confronted to placebo, with the primary endpoint being, again, the overall response rate at 25 weeks. So the study design is almost superimposable to the ENLIVEN study and will be used also for the investigation of pimicotinib. Patients who entered the study had to have a pathologic diagnosis of TGCT with evidence of symptomatic disease. So these patients also were investigated for response based to the assessment of changes in the volume, and also all the quality of life endpoints that, as were said before, are very important for this disease, that were used also in the ENLIVEN study, was also included in this protocol. So quality of life, meaning pain changes, range of motion, brief inventory pain, and so forth. The patient population here was represented by 83 patients included in the vinceltinib arm and 40 patients included in the placebo arm. The two populations were well balanced with a median age of about 40-45 years, meaning that we are treating a young patient population. The mostly affected joint was knee, and this is expected, as this is the most frequently involved joint by TGCT. And the majority of the patients had surgery before starting the systemic treatment. And the vinceltinib showed to be very active in the disease, with an overall response rate at week 25 versus placebo, of course, of 40%. It's also interesting to notice that patients who received placebo didn't experience a meaningful spontaneous tumor regression. This is also very important. And as you can see from here, we also had patients who at week 25 had a complete response. The duration of response is basically very long, meaning that all patients who continue on treatment continue experiencing a response to treatment. And what is even more important, all patients benefited in terms of improvement of all the symptoms, pain, motility, ability to run the daily activity. And this was not necessarily related to the presence of a RECIST response. So tumor shrinkage to reach 30%, it's not always necessary to experience an improvement in symptoms. So for us, it's much more important to observe an improvement in the quality of life at the price of a low toxicity compared to tumor shrinkage at the price of an increased toxicity. This said, the side effects were mild with no major toxicity, and particularly with this drug, no severe liver toxicity was observed, no cholestatic cases, no patient who died of treatment, and this is of course very much important. Among the most common side effects we observe, all reversible at the time we stop the treatment. There is a periorbital edema, which is really induced by the mechanism of action of the drug, and rash. These are two side effects that sometimes impact the quality of the life of our patient and requires a decrease in the dose of the drug. Also, what is very important, the phase 1-2 study that compared to the phase 3 study allowed also patients pre-treated with the other tyrosine kinase inhibitor showed that having been treated with another tyrosine kinase inhibitor does not prevent a response to vinseltinib. And I want to complement the picture that Bill showed you before. So that patient with the arm that was treated with pexidartinib at a certain point stopped the treatment. She experienced progression pretty fast, and she was started in this study to vinseltinib with a new response, and she's currently still responding to the drug. The duration of response, as said before, also in the phase 2 study is confirmed to be very long. And again, even the phase 1-2 study didn't show major severe liver toxicity. So now you have again to check the QR code. And I think we can move on to the other compound, pimicotinib. This is another oral switch-control tyrosine kinase inhibitor, again selective against CSF1R. The drug was investigated in another phase 3 study, Maneuver. This study confronted pimicotinib that was given to patients every day at the dose of 50 milligrams per day versus placebo. Even according to this study design, 2/3 of the patients were randomized to the active drug, 1/3 to the placebo, and the primary endpoint was again the overall response rate by RECIST at week 25. Patients who entered the study had the same characteristics, meaning TGCT with locally advanced disease, not amenable of surgical resection with symptomatic disease. And as in all the other studies, this study had a part 1 and a part 2. At week 25, those patients who were on placebo were allowed to remain on study, receiving now the active drug. So again, we confirm that pimicotinib showed to have a very high activity in this patient population. In this case, the overall response rate by RECIST was 54% compared to 0 with the placebo. And again, the treatment, the response to treatment lasted basically for all patients who remain on treatment. Again, the waterfall plot showing that almost all patients who received the drug experienced some level of tumor shrinkage at week 25, and no cases of spontaneous regression were experienced but in one patient here. Then again, also tumor volume score showed a response, and all the patients had an improvement in symptoms. This again is the most important aspect, no matter the extent of the tumor regression that was observed while on treatment. Patient had, even in this study, a good, I would say, safety profile, experienced a good safety profile with no serious adverse event, meaning no liver toxicity, no cholestatic effect. And again, the most common side effects were related to the mechanism of action of the drug, pruritus, periorbital edema, rash. Very similar to what we observe also with the vincertinib. With pimicotinib at the ESMO were presented the result at a longer follow-up for patients on treatment for at least 14 months. The tumor was shown to remain under control. And again, the overall response rate, as we saw for pexidartinib and also for vincertinib, increased over time, meaning that for those patients who decide not to stop the treatment, there is a progressive tumor shrinkage. Also, the control of the symptoms was confirmed for all the period when the patient received treatment across all the parameters. And again, also at a longer follow-up, there were no signal of major toxicity and liver, in particular liver toxicity. So here again, another one. And now we have a case.
Yeah, so we're going to talk a little bit about Christopher. I just want to say to peer review that the iPad went down, so I don't know if someone can grab that and get us booted up for the questions if possible. So if you remember, Christopher was a 32-year-old restaurant worker, had an arthroscopic diagnosis of tenosynovial giant cell tumor, progressed unable to work due to limited range of motion. So first, what I thought we could do is just have Dr. Randall talk a little bit about the joint so we can understand what we're dealing with, and then we can think about how a patient would come through the clinics if they presented to orthopedic oncology and what thoughts would be, and then what treatment options would be recommended.
Yeah, so, it's a lot of listening. And I try to book these patients towards the end of the day if possible so that we don't have to rush through it, because we really need to dive into what are their expectations, and that in a case like this, cure is unlikely, but functional improvement and pain improvement are definitely on the table. Prior to CSF1 inhibition, we would have definitely gone to surgery with this patient. We can go in multiple times in the front through arthroscopic approaches, and in the back, you really got only one chance to do a really good job because you get all that scar formation around the nerves and the vessels, and that can be very morbid to go back on again. But in the current era, I would definitely be bringing this patient to our tumor board and having the patient probably see Janai Karasher, who's our medical oncologist, for consideration of systemic therapy. So we would have a long discussion, and it could go either way.
Yeah. And so, Sylvia, just say you were the medical oncologist in the DMT, and Dr. Randall said, Dr. Stacchiati, would you treat this patient? How do you approach?
So first, I have to say that I'm a European oncologist, and this could make some difference. So the very good news is that in 2025, vincertinib has been approved both by FDA, but not only, also by EMA. So in a few months, we hope that we can prescribe the drug. And we don't know what criteria we will be given to make use of the drug. This is a limitation that we have to consider. Outside these, in Europe, we have access only to imatinib, and so usually we can prescribe that drug without major problem. And we, however, are considering an off-label drug. So we try to be not very much let's say, open to the prescription unless it is very strongly needed. So if a patient really cannot undergo any surgical resection and is complaining of side effects and there are no other comorbidities, for sure we can consider imatinib. If instead we have clinical studies ongoing, of course we can suggest the patient to participate into a study, and once we will have access to vimseltinib, this for sure will be our first choice. The final comment is that I believe symptoms are very subjective, and there can be patients that can tolerate very well the symptoms, and they can prefer to wait for starting a treatment that sometimes can give side effects, while for others this is very difficult, and so the need for a treatment can be seen earlier in this case.
Yeah, I would agree too. I mean, I think it's really sitting down with the patient. And look, a lot of times patients can benefit from surgery, right? So they have the post-operative recovery period, but can often get significant time without disease growth or recurrence in a way that affects them again. But we would really sit down and have the discussion if treatment was right. And as I mentioned before, what would be the goals of treatment? And this may be a young patient who wants to get back to work and is worried about recovery from surgery. And so starting a medication may be the right thing for them. One of the questions asked about, the responses. We expect all of these diseases to respond to strong CSF1R inhibition. Again, they may have variable shrinkage on scans as we would measure, but we really look for is that improvement in symptoms. And most patients know what their symptoms are, and they can even differentiate TGCT-specific pain from osteoarthritic type of pain, right, which we can help with medications. When we start drugs here, we, at least in my clinic, will often say arbitrarily we're going to use the drug for about a year. We're going to try to get a maximum response of that drug, and then we're going to stop it and see how well we do off treatment. Because it's also hard for, especially younger, active people to be on a medication for a year, because that also can affect the quality of life and they can have symptoms, right? So setting those parameters and really thinking about what's the right way to use a medication. Follow-up is often very difficult because we don't need to get scans all the time. We can look at how the patient is doing symptomatically. And even when we stop the drug, we don't need to treat again at the first sign of a recurrence. But if the tumor grows or is causing joint damage, we can revisit the same treatment strategies, right, that we just spoke about. Sylvia, for patients with prior treatment of pexidartinib like yours, if you did go on to a second drug, do you think resistance would develop, or do you think one drug would have more preferential response to the other drugs?
I have never experienced any kind of resistance to selective MCSF1R inhibitor, while we had patients who did not respond to imatinib. That is clearly a dirty inhibitor. So of course, it depends what access we have to different kind of drugs. So for me, in case of a progression, maybe for toxicity and the need to reduce the dose to one of these compounds, would be logical in case of a patient needs a drug to move to a different one of the same class. Yeah. Side effects sometimes are different, and this can also be a criterion to select one versus another drug. For some patients, it's very difficult to accept whitening of the hair, for example, or rash, or periorbital edema, and not all the drugs are equal in this regard.
Yeah, I think those are good points, because counseling patients on the different drugs we have in the United States become really important, right? To talk about what may be right for them. Do they want to go through a REMS program, a food effect? Some of the features of the drugs. But we have to watch patients very closely when we start medications. We spoke about the REMS period. It's protocol. It's recommended for vimseltinib to have monthly blood draws for the first 3 months, and then every 3 months with them.
And sorry, another comment that we had even recently, a patient who initially had a very good response in terms of symptoms, and then while on treatment with different of this compound, they had worsening of the pain. And we were a bit worried about disease progression, while radiology didn't show anything of that. And what we learned was that the arthritis instead worsen over time. So there can be cases where you can see that there is pain coming back, and this is not because the disease is becoming refractory to the treatment, but because of the inflammation and the alteration of the joint that might require prosthesis replacement.
Yeah, and I'll just ask Dr. Randall that if we put Christopher on drug and 6 months after drug, his symptoms are better and we had a tremendous response, and we're thinking about stopping drug, would you operate on that patient, or what would you do?
That's the question,
That's
right?
the question.
That's the question. I don't. I've had that scenario, and I've gone both ways depending upon the conversation with the patient. Candidly, if someone wants, some people will come in wanting to be very aggressive, and others will say, I'm actually in a good place now. I really would rather not have the surgery, especially if I don't know, if it's shocked it to the point that surgery has a better cure rate. We don't know the answer to that. We don't have any sort of neoadjuvant type of trial data. But we will follow those patients very closely, and if they do, those that don't elect surgery do start to progress, we go right in.
Yeah, I think that's, interestingly, I think they were looking at some of the original data from the Enliven study. Very few patients actually went to surgery after the use of drug, and I think the reason is patients were doing so well that there wasn't a thought of a need for surgery. But we also know that drugs are not curing patients, right? There are diseases which can stay stable for long periods of time, but not curing people, right? So both of our treatments are more symptom control and disease control, and that's very important. And this is just an example of the response that the patient had, at least radiographically, with symptomatic improvement. So some conclusions, and then we'll get to some of the questions and answers, is that localized tenosynovial giant cell tumor and diffuse tenosynovial giant cell tumor are clinically distinct entities. Most of the time, we're talking about diffuse TGCT. I will say in the pimicotinib study, there were some patients with the localized disease. So, that's something that we'll learn from. Surgery is the mainstay, but we have good medical treatments, although most patients, can be watched, right? That's really important with supportive care. Medical therapy can be indicated in some patients, and patients are very responsive to it. And as we always say, team-based management inclusive with the patient is important to understand what's right for them. All right, we're going to go into some questions. One of the questions, again, that I kind of mentioned my practice, but it says at what point is a patient's treatment does the physician decide to suspend the treatment? And it's a weighted question because it says physician. And one thing we'll talk about is I think patients are really in control of their medical management in TGCT. But Sylvia, how do you approach it? And Laura, when they come back to the surgeon and say, how long should I take this? What do you guys say?
So I believe that the phase 4 study of pexidartinib, even though it involved few patients, was very instructive because showed that at least 50% of the patients who discontinue the treatment do not progress, do not experience progression. So for me, the question is more, after how long do I have to stop a drug to achieve a disease control that can last for a reasonable period of time? I think we do not have an answer because the phase 4 study had, for the majority of the patients, a very prolonged treatment before the interruption. We usually try to prolong the treatment at least for a year. Then after a year, we rediscuss again with the patient if the patient needs to continue or not. And also based on the location of the tumor. So I have a patient with a disease located to the cervical spine. Of course, there is a danger in stopping the treatment, while when you have the disease located maybe to the knee, the risk is very low.
Yeah. Do you have anything to add?
Yeah, so I have said up to, but not in excess of 2 years, and then at 2 years we'll reassess. We may stop earlier. But if we do stop, as I said, the diagram is, do we go to local control immediately, or do we just watch them carefully? But usually at 2 years, we will stop drug.
Yeah, and there are also some questions about side effects. Again, aside from some of the, on-label side effects, cholestatic hepatotoxicity, transaminase elevations, where there are very, strict guidelines in the label of how to dose reduce all drugs. I think what happens is after patients get initial response, they realize that probably lower dose or not necessarily pure continuous use of the medication is needed. So one of the ways they mitigate side effects is often to take holidays of drugs. So if we talk about periorbital edema and vimseltinib, patients will come in and say, I've been pretty good for the drug, but I saw my, eyes swelling up, so I stopped it for a few doses, it got better. And I think that's all okay, right? I think patient has a lot of agency in how they use medications in this disease, because ultimately they have to tell us, if they want to or need to continue it. There are a lot of questions in here about which drug do you choose, pexidartinib or vimseltinib. It's tough, and I don't know if you guys have comments on that. I know, Sylvia, you don't have pexidartinib, so, do you do imatinib or vimseltinib, but how do you choose a drug?
Ideally, if I were to access all the drug, for sure I would select the one with the less risk of side effects for my patient, no doubt about that. So activity is relevant, but we see activity across all the agents we have. And I think that minimizing the risk of major side effects is the most important thing, because we are targeting quality of life.
Yeah, and in that regard, pexidartinib, which is a great drug, does have a REMS program. It does have a food effect, which can be cumbersome for patients to eat a specific amount of protein twice a day. You do have to worry about the white hair, and some patients, really in the U.S. have waited for vimseltinib to start that drug. But again, we also do have discussions about vimseltinib versus imatinib. With vimseltinib, we are just learning about usage, right, and what's the best way to do that. Pimicotinib, I imagine, hopefully will be coming available too. I suspect it would be NCCN compendium listed and approved in multiple countries. And I think that'll be another choice, right? I mean, you've probably had more experience with pimicotinib than I have. I mean, would you have a preference, one over the other?
No, I could not say so. I believe that, again, we need to adjust the dose to limit the side effects and optimize the treatment. So for us, it's important to get an improvement in the symptoms, to release the symptoms, but not at the price of a high amount of side effects. So for me, there is not a big difference. The difference is more related to the need of adjusting the dose. And also, I believe we are lucky because in 10 years, we now have different agents, while at the beginning we had nothing. So this is a very good example of how we can develop all together treatments that can really impact the quality of life of patients, and also of the doctors that have something good to prescribe.
Yeah, and one of the questions was interesting. Is there any contraindication at all to any of these drugs where you would say, I will not, recommend that one too?
I mean, yeah, I believe they are. So there are patients who have chronic hepatitis, or they have cardiac failure. So, I mean, there are conditions where the need for a treatment must really be very much important to risk a complication or a worsening of a concomitant disease. So these are the conditions where we don't like very much to start the treatment unless it is really needed.
Yeah, I mean, there's an interesting question about here is, have pexidartinib, we have vimseltinib, why a third drug? I think that's interesting too, because it's nice to have options for patients. And I think, like was spoken here, we had pexidartinib available in the United States, but not in Europe. Vimseltinib is now available in Europe, but we're also talking about global availability for our patients. One of the things that may be interesting in the U.S. is we don't know if payers will decide which drug patients can get. If they actually contract with certain drugs, is that what, there will be a paradigm for people to take, and then how will we interact with that? And Laura, one of the questions is really about how do joint destruction come into this? Do you ever see scans where the disease is relatively stable, but you see more joint erosions, and you would say start a medication. Or if you do a knee replacement, does that treat the disease or does that just help the joint?
It's a great question. So, and there's a lot to get into there. I'll just try to keep it brief. So we know from the data from the colleagues here and others who've published that we think there's probably secondary osteoarthritic incidence of maybe 20%. But, you know, osteoarthritis in and of itself is pretty common, and we're talking about a group of patients that are getting into their mid to later part of their life, and so they may have a predisposition to osteoarthritis anyway, and maybe the TGCT is just catalyzing it sooner, but they ultimately would have done it. So I want to be very careful in this concerns around secondary osteoarthritis because they may be real, but not everyone does. I've got lots of patients who I've followed with really bulky disease over many years who, one, don't show any progression at all. We've published, you know, about 60% of patients with bulky disease over a 2-year span don't progress, but then who've never developed joint erosions. To the second point about TKAs or total knee arthroplasties or any sort of joint replacement, it doesn't take care of the disease, and the complication rates are higher. So if the thought is, I'm going to go in there and resurface the joint and problem solved, wrong. You're going to have higher incidence of loosening, so you really do need to control the disease. Anyone who I'm going to do a joint replacement on, I would definitely talk about contemporaneous CSF1 inhibition because the prosthesis is at high risk for failure.
Yeah. And so after this session concludes, you can scan the QR code to visit peer review, to claim credit for the CME and access the activity materials, and stay tuned for the online activity that's based on this event. So thank you so much for joining us tonight, and I hope you enjoy CTAS. Thank you.